And hello, my name is Aiden. It's very nice to meet you. Here's my student card. Okay, and I guess I'll get started. So, in scenarios like this, uh, I think it's very important to distinguish that as doctors and as physicians, we can't control what the diagnosis or outcome of the patient's health is, but what we can control is how we communicate that, right? We can control what we say and the feeling that the patient ultimately has during our interaction. So when trying to prioritize that, I'll first start with things that I'll think about in the moment and some considerations I'll make. Next, I'll discuss what I'll actually tell the patient, and then I'll discuss our future outlook, right? What are some things I'll look for in the future? So immediately when I see this scenario, I think of a few things. The first of which is the patient is obviously in a lot of distress when it comes to the pain and the immediate treatment of cancer. And this is totally expected and normal. Cancer is a very scary prognosis, and there's a lot of weight that comes with that word. So, as the physician, it's our job to uh, make that more clear, but what the path forward looks like, kind of delineate for the patient and let them know this isn't as scary as the word might seem, right? There are things that we can do to help this progress. So what I would immediately tell the patient is address their needs. And their need one is their pain. They don't want to be in a lot of pain during their treatment. So I can let them know exactly what to expect in regards to that. I mean, cancer is very variable, and the amount of pain they'll feel relies heavily on their prognosis. But what I can say is that we're going to do everything we can to make sure that your pain is lessened. We'll give you medication A or medication B that will prioritize the fact that we're going to make sure your pain is less or as comfortable as you'd like it to be. Um, and you let us know. We'll have a back and forth communication on what you'd like and what you'd like to see going forward. The next thing is the immediate treatment. So this is again an area where we can step in and say, uh, have a dialogue with the patient and say, what treatment would you like? And inform them of the options that are available to them. I think very importantly, and this goes to the second part of the question, which is the ethical obligations, is we want to uphold the patient autonomy and say, here are the options. This is my informed opinion, and of the doctors around me. This is what the healthcare guidelines say is the path forward. And then we have that conversation with the patient and allow them to decide what they want based on their needs. So that, of course, goes hand in hand with autonomy and hand in hand with non-maleficence and beneficence for the patient. The next consideration I'm making is it's a little bit of a niche one, but it's in regards to the 9 months to live. And I'm pulling on a quote by Atul Gawande in his book Being Mortal that I think is pretty applicable to this scenario. And it's that every data point in a stat like that, which is the patient has 9 months to live, every data point is a unique patient with a unique environment, with unique people around them, with different genetics and a different diet, and just a very unique lifestyle. And it would be remiss to group all these patients into a simple number, right? To binarize this into all these patients, if we take the average of their outcomes, this is the number that we output. But rather, you look at each patient individually. So I would stray away from telling the patient they have 9 months to live or even believing that in general. I think it would be much better to uphold the hope that the patient might have or say, we're going to do everything we can, as opposed to putting an expiration date. And then the third consideration I'm going to make is that the actual practicality of communicating this information. So it'll be making sure that I have time booked off after my session. I don't want to have to rush them out of the room. I want to have time to sit with them and really obviously have that back and forth. So booking the time after, as well as making sure they have a family member in the room with them or whoever they'd like, who is comfortable having tissues nearby, and etc. So now when it comes to actually talking to the patient, it would of course be very gentle but forthcoming, right? Because I wouldn't want to beat around the bush. That's one of the things personally in my life I've experienced is sometimes when there's difficult news, a physician will want to try to beat around and play around as long as they can before delivering that punch that will ultimately come. Um, I believe it would be the best call to just come outright and say it to begin with, very calmly and very matter of fact, and then we'll discuss the details of it afterwards. So I would tell this patient, you do have cancer. this is something that we can absolutely work together with. And once you're comfortable, I know this is a lot to carry at the moment. I'm going to be here as long as you need. I've booked off my next appointment. When you're ready, and maybe that's not today, we can maybe discuss treatments. We can discuss any concerns you might have or how we can move forward from here. And then the last thing I'd like to touch on is in the looking towards the future, right? Because I think every good physician shouldn't just be stuck in their appointment with the patient. They should be looking at the longevity of care that they have. And the biggest thing here is follow-ups, right? By the end of this session, I would want to have a follow-up booked with the patient. I would at least want them to have some connections, say if they want an oncologist or they want a second opinion, maybe. Just being able to give them something to look forward to so that they know their treatment isn't in some purgatory, right? Is that they have some clear path going forward. So yeah, that would be the overall consensus. And welcome any follow-ups.
Thank you very much for your response. So, how would culture or religious beliefs influence your discussion with the patient and their family?
It's a really good question. I think that goes hand in hand with knowing your patient and building a good relationship with them is realizing that everybody has their own beliefs and cultures that influence what they think about certain outcomes or their health. So, in line with that, I would want to know more about the patient's health and beliefs, right? If we can focus on this from the patient side or from the physician side, but I'm going to focus on it from the patient side because it really does impact the way that people approach news like this or approach healthcare scenarios. So, for example, if they're a religious person, perhaps we can have their religious leader come in the room or be present with them, or maybe even have an appointment or follow up with this leader. I know that's something that a few religions really encourage is having that FaceTime with religious leaders, as well as certain cultures. For example, we live in Canada. 1 in 5 individuals in our country are French. Another 5% of the individuals in our country are of Indigenous descent. So being able to navigate both those cultures. I know some hospitals do have Indigenous navigators. They can't help with that, but it's also good to have that knowledge to begin with. So connecting an individual with whatever person is available in the hospital or outside of the hospital that can help them navigate this through their own personal cultures. So, for example, in my culture, we do this thing. It's to ward off evil spirits or to promote good health, and it's called the burning of Esfand, which is a herb. So knowing that is a really cool thing because if a physician came to my mom or my dad and they said, "Oh, maybe that's something we can do tonight," or "I encourage you to do any practices you like," for example, if you want to burn Esfand, then I would find that very touching and personal, and it would feel very heart to heart. So, yeah, going above and beyond, I think in that regard is very special as a physician.
Thank you.
Thank you. Oh, shoot. Mix up the time. I should have said my whole mantra. That's okay.
You did amazing.
Thank you. Thank you very much. Yeah, I was worried I'd be out of practice a little bit, so I'm glad you said that.
No, you are still very sharp.
Thanks. Should I get ready for the next question? Read it now. Okay, sorry. I'll start at 37. Hello, my name is Aiden. It's very nice to meet you. Here's my student card, and I guess I'll get started. So, there's a lot of information in this question that I think it would be useful to kind of delve more into. So, because it's a very tricky situation. The first thing I'll mention just outright is that I, like every person, would like to live. And if there's an outbreak of this incredibly contagious disease that's life-threatening out there, my obvious first instinct would be to take the vaccine and be okay for my family, for myself, for everything. But I realize that when it comes to healthcare, there's an extreme privilege in being a healthcare worker. Well, it's two-pronged. A privilege in being able to access these new health vaccines, but also the con of being surrounded by this sickness. So it's important to navigate that properly. So to break up my answer, I'll first talk about some things that I'll consider before jumping to any major conclusions. My ultimate decision of if I would take it or if I would not, and give it to another person, and then maybe future ramifications that would come from that decision. So to start, the first thing I'd want to research more about is what exactly is this disease and how life-threatening is it? For example, is it only life-threatening to those that are immunocompromised or those that are above a certain age, or is it life-threatening across the spectrum? Because that would influence my decision making as well, depending on how at risk I am. The second thing I would like to think about is that 50% is a very scary number. Right? If I thought there was a disease that 50% of people were dying from, I would really want to take the vaccine. But I think these numbers, it's important to look deeper than what the numbers suggest. So, for example, uh, much like my first point, if individuals that are succumbing to the disease are already immunocompromised or are in the ICU, or individuals that have a comorbidity or with other viruses in the hospital, then that changes my risk susceptibility and ultimately my decision coming from that. And the last thing I want to consider is the question states that I'm a senior healthcare administrator. That role is a little bit vague in a hospital. So, for example, am I patient facing? Am I having a lot of contact with those coming in that might have the virus? Or am I in a back room somewhere on the fourth floor in a cushy office and I won't have to really be interacting with patients all that much? Because again, that would increase or decrease my risk and ultimately change my decision. But assuming that let's say that those things, let's say I am patient facing as an administrator, uh, but let's say that the 50% rule is only for those that are comorbid or immunocompromised. I think ultimately it's my priority as somebody that works in healthcare to uphold the values that myself and my institution stands for, right? There are individuals out there that are immunocompromised that will likely be wanting this vaccine. And I'd actually be curious who I would be giving my vaccine to. For example, has enough vaccine come into the public where everyone who's immunocompromised has already been taken care of? Or is that a consideration I have to make where if I don't take it, I'm giving it to someone who would benefit from it more than I would? Again, a very important distinction to make. So, with those acknowledgments out of the way and kind of discussed, I would err on the side of giving this vaccine to somebody who is immunocompromised if that individual exists, because obviously, as someone working in healthcare, I would want to do the most good for the public and for my society. I think even working in a hospital and seeing the individuals that come in and are desperate for care and are desperate, have families that need them taken care of, I think it would be the ethical decision for me to give this vaccine up if it benefits another person more, stipulation one, and two, the risk to my life is not as high as maybe these numbers make it seem. But again, that answer varies depending on these certain things. Uh, so yeah, I'm welcome to take any follow-ups. Oh, excuse me. And
Mhm.
future ramifications of this decision are obviously plentiful, right? Depending on if I take it or if I don't take it. For example, if I take it, I think there could be a stigma surrounded. I could break a little bit of the trust that individuals might have in healthcare centers. They might think that not nepotism, but they might think that people that work in healthcare, just because they're associated with the field, may get unfair access to certain things like vaccines that the general public doesn't have. And that could potentially spark controversy with the hospital and with myself in general. If word gets out that a healthcare administrator that was behind the scenes got access to this vaccine before immunocompromised individuals in the community, I can definitely see how there could be some backlash from that. So it's important to consider not only the effect it'll have on me, the individual, but it's also important to think the broader community, how this will impact the hospital's reputation, my own reputation, and overall the public's uh, view on healthcare.
Thank you very much for your response. I 100% agree with you. So, I want to ask a follow-up question. What ethical framework best supports your decision? Do you think utilitarianism is the right call here? Do you think fairness is the right call here? Which framework, ethical framework, would you want to go with?
It's a good question. I think it's Beauchamp and Chaldress, I believe, that made the four ethical principles. And one of the biggest things I at least gained from those principles is the fact that they don't exist in a vacuum. You use each and every one of them in each and every decision. So it's a mix of all four of them. I'd say there are aspects of justice in this, right? You'd want individuals that would gain the most benefit to have access to these vaccines. There is the principle of non-maleficence, is I don't want to do harm to an individual by withholding a vaccine from them. I also want to benefit them the most, especially if my life, the risk contained to my life is minimal. And of course, autonomy. Uh, I feel like that one probably has the least impact of the four, just because, of course, it is their opinion to take the consent to take the vaccine, but that doesn't seem to be a central part of the question. I do also believe utilitarianism would be the closest ethical principle framework that I'm working at here because it's very much weighing the pros and cons of me taking it or another person taking it and simply counting them up and seeing which one would have the greatest benefit for the most amount of people. But again, I do believe that you take an oath as a healthcare provider. Even as someone like a healthcare administrator, you are working in a hospital that is public facing. So there are ethical frameworks that you have to abide by. And I do think there are aspects of all four of the main ones in this.
Thank you. Do you think age, occupation, or expected years of life should factor in when we decide on how the vaccine is distributed?
To an extent, I believe yes, they should. I believe because the biggest thing we're thinking about here is risk of death, right? And age is a clinical indicator of the ability of an individual to succumb to a virus or to thrive. And is basically their immune system, how developed is it? How lacking is it? So I think age should play an impact to some extent. In terms of other factors, I do believe that they would infringe on justice in many ways if we prioritize some groups over other ones based on factors that aren't strictly healthcare related. So I would like to delve more into that, but unfortunately, I am out of time. So thank you so much. Hello, my name is Aiden. It's very nice to meet you. Here's my student card, and I guess I'll get started. So, I find this one to be a tricky scenario, and I think mostly because you're trying to balance a lot of things, right? If I was in this scenario, I'd be thinking, number one, what obligations do I have as an employee of this store? For example, are the individuals in this store, is their safety at risk with this gentleman in the store? I would also think public safety is another factor I definitely want to consider. Like, for example, my mom, my grandma, people in my immediate family, everyone is out there on these public roads. So if I think that this gentleman poses a risk to the safety of those in the general public, it would be in my best interest to take the proper steps to make sure that risk is mitigated. And the last thing, I'd want to look out for this gentleman's safety as well as my own. Coming into the store staggering and disoriented, there is, of course, a chance that uh, these things go together and he potentially poses a risk or a danger to my safety or his as well. For example, if he came here with a car, if I noticed car keys in his hand, this could be something that would potentially pose a risk to him. We wouldn't want him behind the wheel. It would also impact public safety. So suffice to say, there are a lot of different things that I'm thinking of, a lot of different stakeholders at play. So when approaching this problem, I'd first like to consider the things that I would think about before taking any actions, what actions I would take and my justification for them, and then potentially the future ramifications or what I would do in the future as a result of this action. So I've already discussed the stakeholders that are at hand. The next thing I want to discuss is to take note of a few more things. For example, I mentioned car keys. That's a really big one. If he has car keys, if I notice them maybe hanging out his pocket or they're in his hand, then this escalates into something of public safety. This is now where I need to intervene for the benefit of everybody. However, and discuss what intervening looks like exactly. But one thing I'd also like to mention is that it's important to not make assumptions in situations like this. For example, there's this study, not this study, there was this gentleman in Kentucky, I think it was Kentucky, where he had this unique and rare disorder where his stomach produced alcohol. It fermented alcohol on a daily basis. And even when he didn't drink, he had the smell of alcohol on his breath. And he got pulled over frequently. And a lot of things came about from that because people didn't know about this disorder. So an older gentleman who's already at risk for many things, who likely already has gait issues, not likely, but there's a potential for gait issues and various other things. If I see this individual staggering or seemingly disoriented or even the smell of alcohol, while likely that these things could be connected, I don't want to immediately jump to that conclusion, right? I want to consider these things individually. So what I would do is I would offer this man, he's buying a coffee, so I would offer him a snack as well. I think human kindness is a really important thing, and it creates a low barrier entry point into a conversation with this man. So I offer him a snack. I gauge what his reactions are like, how he's responding to my questions, and I might ask how he's getting home in a very non-confrontational manner. And a few things can come about from this. So I'll now transition into the actions that I'm taking once I've taken note of the preliminary things. So if he says he's getting home with his car, then that's a situation where I would be first offering to get him an Uber or a taxi. I would simply say, in a manner that's not assertive, but basically very calm and matter of fact, I could order you a taxi or an Uber if you wish to get home safely. I'm not sure if you're in the best mental capabilities right now to get home. And I'd ask where home is. For example, if he's 5 minutes away, maybe he can walk home, or maybe he walked here even, you know. I would offer the Uber a taxi. If this is something he refuses, or perhaps he gets angry at the suggestion, maybe the effects of the alcohol are taking place, and it is in fact the case that he's drank alcohol, then this would be a situation where I would first say, if you continue this, or if I see that you're driving home, I'll have to call the police. And if, of course, if he continues, I would escalate and call the police because uh, priority one is making sure he doesn't get on the road and put his safety and others at risk. And if, of course, he doesn't, he stays put or allows me to order the Uber and the taxi, we would move forward with that path. And then transitioning into the future, what I would think about, I would get his phone number so that we can maintain contact. And when the Uber comes, he would get in, and around 20 minutes later, I would probably send a text and say, "Hey, have you got home yet? Are you safe?" Just to make sure everything went smoothly. And this also offers, again, it makes sure that the interaction doesn't put my place of business at peril. This man doesn't walk away thinking that I ordered him to do anything, but it was a very friendly interaction. So, yeah, that would be overall how I would handle this.
Thank you very much for your response. So, uh, if you were busy and there were several customers waiting, how would you prioritize the situation?
Yeah, it's a good question. My previous answer really hinged on the fact that I would have some one-on-one time with this customer, but because there are other customers in the store, number one, what it would do is it would change my framework to also prioritize their safety a little more. For example, I wouldn't allow so much time to be talking with this individual because there's a chance that he might, yeah, pose some sort of risk to those in the store. The second thing it would do would be that I now have less time to interact with him. So of course this changes. For example, if I do see car keys in his hand, I would simply a little bit more assertively say, "Hey, could we please not drive today? I can order you an Uber, I can order a taxi. If you have a friend or family that can come pick you up, that would be great as well." But I, of course, wouldn't want the other customers to have to wait for this interaction. Of course, a little bit because they would understand the gravity of what's taking place. I would also want to make sure that their uh, business goes about unharmed and that they feel safe in my store ultimately.
Thank you. What if he appears homeless and has nowhere safe to go?
Yes, that's a good question. There are certain scenarios like this. For example, it's a great point. Homeless is one thing I didn't mention in my original answer that would be something I'd be thinking about. Another thing is just being an older gentleman to begin with. There are certain vulnerabilities that come with that. For example, the loneliness that elderly individuals face, it many times can move them to certain scenarios like this. But specifically talking about homeless, if that comes up in conversation, then it wouldn't just look like an Uber or a taxi or calling the police. It would kind of change. It would be, let's connect you with a social worker. Right now, my priority is getting you to a safe space. So while that might not necessarily be offering my home, because I would want to look out for my safety, it would be making sure that I find him somewhere safe to be. I would call local shelters. I would call maybe he has friends or family that could take him in potentially. I wouldn't let this man just go about his business without somewhere to be. But that looks like time. So thank you so much.
Thank you.
Hello, my name is Aiden. It's very nice to meet you. And here's my government ID. And I guess I'll get started. So, this quote is a very interesting quote, and I think there are two ways that you could take it. The first way is this is a fireman giving instructions to his fellow firemen, or it could be a metaphor for something deeper. And when I read this quote, I get the sense of cause and effect. It's a metaphor for cause and effect. So, what does that mean exactly? Well, in the instance of the quote, where there is smoke, there is fire. This means that while you might see smoke, you might be tempted to think that this is the problem, right? You might do everything you can to address the smoke. Maybe buy a fan, buy a ventilator, blow the smoke away so that it doesn't impact the fellows around it. Um, but the real issue is the fire that continues to produce the smoke, and it's really the problem that you should be focusing on, the root cause. So, what does this look like? I'll tie it specifically to healthcare. I think the cause and effect, there are a lot of ways you can take this. The way I'm going to take this is specifically the ER, crowded ERs, and the overall problems that we face specifically in Canadian healthcare. So in this instance, the smoke is ER crowding, right? You see a bunch of individuals that crowd the ER. You think, oh, the immediate solution should be to hire more ER physicians. It should be to increase the amount of rooms that are in these hospitals. While these might be good temporary fixes to the problem, it doesn't address the root cause, right? It doesn't address the fire. And the fire is that we have a physician shortage and many people do not have access to a family care physician. And when you look at it from this lens, then not only your solution becomes better, but your analysis of the overall problem becomes enhanced. So what does this look like practically? A certain amount of individuals in this country don't have access to a family care physician. And this raises problems. One of these problems, one of the effects of this, is that if there's no one to go to for their problems, where are they going to go? They're going to go to the ER room. And this will contribute to a lot of that ER crowding you see. Furthermore, if you have to wait for an appointment with your family doctor for an extended amount of time, it incentivizes you to go to the ER for a quick look, for an immediate fix. And of course, there are many other ways you could take this. So, what I would propose is taking this quote and applying it to our understanding of our system and what solutions that could look like. So, I'll briefly discuss two. The first solution is, and of course, these are both to address the physician, family care physician, getting more people a family care doctor. So, solution one is something called the family healthcare model. Family healthcare model. And it's by Sommet and her colleagues. It's a collaboration of many Canadian physicians, but Sommet is one of the main ones. And what this model looks like is that I'll paint a practical example. Right now, when I go to my family doctor, she's located 20 minutes across the city on the fourth floor of an industrial building. And when I go up there, I wait for my appointment, then I get my appointment, and maybe I have to do blood work or maybe physiotherapy. I have to exit, go down all four stairs, drive 50 minutes across town to the other physio that they've recommended, or maybe 15 minutes to get my blood work done. And it de-incentivizes people from getting their healthcare done, right? The family healthcare model is it has a different approach to this. Like metaphorically, you would get your family care physician, you'd get your requisitions on floor four. On floor three, you would get your blood work done. On floor two, you would get your physiotherapy done. And then on floor one, there's the pharmacy, you get all your medications. Now, this whole model is built around the fact that healthcare should be a headquarters. It should be one area where you can get all your healthcare related things done, and it creates a more collaborative approach between all the healthcare workers in the building. So when this was proposed, it was proposed, of course, as a solution to not only get people more family physicians because we'd increase the capacity of these buildings, but it would also make it so that there's more collaboration between these different faculties and that patients would actually, they wouldn't have to spend a whole day going to different places to get their healthcare done. So I think this is a really genius model that's been proposed in Ontario. The second thing I'd like to say is of course, hiring more family physicians is a solution, but of course, things aren't that simple, right? There is legislation in this province and in this country that maybe makes it difficult. So one of those things is the family care payment model, right? The way that we pay family physicians. Currently, they're paid on a fee for service, meaning that whenever you go in to see them, they get a fixed lump sum of money. and it almost incentivizes them to see you more. So that looks like shorter appointments and more appointments. But if we change this payment model to, I believe it's called capitulation, where you give them a fixed amount per patient, and every time that that patient shows up in the ER or shows up in another walk-in clinic per se, they get a certain amount deducted from their fee. So this incentivizes them to make sure that you show up less to the ER or to these different avenues, and it increases the chance that they give you good quality care and they focus on the future as opposed to keeping you coming back. Now, of course, there are not many, but there are downsides to this framework that should be discussed. The one that's most common is, of course, physicians in low socioeconomic status neighborhoods would be unfairly taxed more than those in high socioeconomic status neighborhoods, because, of course, these are one of the biggest predictors for health. So the individual in the low SES neighborhood would have their 1,000 or whatever their fee is cut more times because their patient shows up in these different areas more. The other thing downside to this is that patients that are above the age of a certain number or that have comorbidities will obviously show up in these separate facilities more, and that's unfair to the physician. So while there are a lot of nuances that need to be worked out, there are broad solutions to this overall problem of getting people family physicians to make sure that they don't show up in ER rooms and to ultimately address the fire and not the smoke.
Thank you very much for your response. So, what is the difference between being cautious and making assumptions?
I think the difference between being cautious and making assumptions, in many ways, they go hand in hand, right? When I think of someone who is being cautious, I think of someone who is careful about the things that they consider and someone who makes sure that whatever decision they take, they've put thought into it, right? And assumptions might be part of that, but I think there is a difference in the fact that those that make assumptions, they oftentimes don't think about the things that impact patient population's livelihood or impact certain areas of their practice that might be very big deals. So broadly, I'll draw a separation between the two to say that in the context of a physician who is context is cautious is one that doesn't make assumptions, right? In many cases, it's somebody that gathers more information, that asks more questions about their patient, makes sure that there aren't things that they just take for granted, right? They don't, there are issues that their patient has. They don't just assume that there's a quick fix. They actually get to the root cause of that problem. Whereas making assumptions, of course, is a little bit of negligence. It's less so being cautious and more so trying to move through the motions. Oh, I see. Out of time.
Thank you.
Thank you. Hello, my name is Aiden. It's very nice to meet you. Here's my government ID. And I guess I'll jump right into the question. So, this is a very interesting one because psychedelics, the question alludes to it, and I've also seen it in my own day-to-day. They're a hot topic right now in healthcare. There are certain studies that are coming out that are saying they have a lot of benefits if taken in micro doses for things like depression or anxiety. And I think as a physician, somebody that's working in healthcare, perhaps working with the legalization process, it's important to do your due diligence, right? To look more into these things. So broadly structuring my answer, it would first be to address any considerations I'll make before discussing the pros and cons. Next, I'll discuss ultimately the pros and cons of legalizing psychedelics and the implications they might have. And then thirdly, my ultimate stance of what my solution would be. So, when thinking about psychedelics, as I alluded to previously, gathering information is extremely important, right? It wouldn't just look like what are the effects, it would be much more in depth. It would be what are the effects of psychedelics in certain populations, in immunocompromised individuals? Do they have better clinical outcomes than other antidepressants or drugs? Uh, what is the rate at which people get addicted to these substances, or what kind of adverse impacts would they have in a lot of patients' lives? And ultimately, the question I'm trying to solve is, do they serve more of a benefit than current clinical practices and applications when it comes to treating depression and anxiety? So one thing that would look like is actually looking at places that psychedelics have been used or have been legalized and seeing what outcomes they've had there. So if I know that country X has legalized psychedelics, I would look at what is their rate of depression and anxiety, how the psychedelics helped that rate since it's been legalized, and what adverse impacts, of course, have come from that. I think it would be super useful. So now going into a big pro I see and a big con. A pro is, of course, the fact that our generation today, or yeah, just people in general today, there is an increased prevalence of depression and anxiety. There are a lot of different reasons this could come about. It could be people are experiencing more loneliness. It could be cost of living. It has grown higher over the years. There are many things, but that's besides the point. The fact is that there's an increased prevalence of these conditions, and as healthcare providers, this is something that we want to solve, right? And obviously, we can't go in there and get them friends and schedule hangouts. So what we can do is treat the depression and treat the anxiety and make sure that their quality of life is improved through the care that we give them. And a pro of psychedelics is that they could ultimately give this effect to the patient, right? They could treat the depression, they could treat the anxiety better than clinical outcomes. For example, my friend is really big into psychedelics. He's part of the psychedelic club at McMaster. And one of the things he keeps telling me is that if microdosed to an appropriate amount, um, psychedelics have a way of treating individuals that have already gone through treatment with other clinical antidepressants and have been unsuccessful with them. They've actually had the ability to help those people, right, in a way that normal practices never could. So the pro is ultimately that we discover a new way to treat these conditions. But a con I see is that psychedelics do have run the risk of being addictive, right? Or there are certain outcomes that could come that aren't that great. So, for example, an individual could fake their symptoms or tell a doctor something simply to get access to a psychedelic from their healthcare provider. And I think one useful thing when looking at the pros and cons and ultimately formulating your decision is looking at similar legalizations. So, for example, Ontario, Canada recently legalized marijuana around 10 years ago, and there were specific reasons that marijuana was legalized. Looking back at the reasons that were provided and then the outcomes that ultimately came about from them would be super useful. So marijuana is also addictive. Looking at the addiction rates in individuals that have been prescribed this through medical means would be extremely useful in applying to uh, psychedelics and saying, is this something that the cons or the pros outweigh each other? Ultimately, my stance for this would be to run a pilot study because this would gain the most information for our specific scenario. So what that would look like is, let's say it doesn't specify where. I'll assume, oh, my bad, Ontario. I'll pick a small town in Ontario and I'll do two things. I'll legalize psychedelics in this area, and I'll also increase medical education in this area towards psychedelics. So that number one, we now have a study in our own location that shows us the effects of these long term. But number two, the individuals in this county also are aware of all the risks that they could be taking on by using these psychedelics and going through these solutions. Of course, I would make sure that the people that get these psychedelics are ones that we are actually dealing with depression or anxiety, people that would actually benefit from them, as opposed to just having loose regulations and allowing many people to access them. And they would be very closely monitored. Our whole goal for this is to develop enough data that we can extrapolate it to the rest of the population and the province and see, do the pros ultimately outweigh the cons, and is it a good treatment for antidepressant and anxiety? And then once this pilot study is over, we then conclude to the next step. What would be super helpful is getting more healthcare professionals, certain people that specialize in addiction studies or legalization of these substances in our province to make sure that we have a team-based approach as opposed to just one individual doing this. Thank you.
Thank you very much for your response. How do you balance individual autonomy with protecting vulnerable populations when it comes to this topic?
It's a good question. Of course, as healthcare providers, individual autonomy is a threshold that we absolutely we uh, yeah adhere to it at all times. But the vulnerability of populations is very real. For example, an individual who's experiencing homelessness or an individual who's experiencing certain downsides or certain things in life, they might be more incentivized to try these psychedelics, and the adverse consequences of them could be exacerbated in these specific patients. So what it looks like is making sure that, at least in our pilot study, we ensure that the individuals that are getting access to these treatments are ones that do not have any comorbidities, right? Won't have any vulnerabilities that might impact the goals of this study, which are to test this medication in individuals that other vulnerabilities haven't come in and diluted the results that we're trying to see. Ultimately, we can't, once they're legalized broadly, if they get legalized, we can't simply stop people from taking them, right? We can, as physicians, what we can do is inform and we can try to make the best decisions. But upholding patient autonomy means allowing the patient to make decisions even when they might go against what you believe, right? So informing is key.
Thank you very much.
Thank you.
I actually really enjoyed your responses. Thank you very much. Those were amazing, to be honest with you. I'm just gonna end the recording so we can speak a little bit.